So if you guys want to say stuff to strangers from other parts of the country, just speak up. Yeah. What is this?
You mean our questions are going to be kept forever?
Totally. What's that? When? January 23rd. Yep, we got it all figured out. Did I tell you guys who's watching my kids?
Mom and your sister?
No. So this is the biggest issue with we can't ever go anywhere because we live in Washington. Both of our families, or at least both our sets of parents, are in Utah. Neither can watch our kids like physically. They're not able to. So like we can't ever go anywhere unless we find a babysitter. So wherever we are, we're always like trying to track down or figure out if there's any like young couples without kids that could just would think it was fun to stay in our house and watch our kids, whatever. Of course we pay them, and we actually pay them well so that they would be excited to do it next time, but it's difficult, to try to find people and get schedules and whatnot. But so before I got in an avalanche, or in the avalanche, a avalanche, like I've been in many. When I was working in the ER, the week before we left to Canada, there was this, young girl that came in. That had just started birth control like a month earlier. She came in like ashen gray, short of breath, looked like she was on death's bed, and she had PEs. I lysed her within like 10 minutes, but she had blood clots in every aspect of her pulmonary arteries, like everywhere, both lungs, like everywhere. If she wasn't young and healthy, she would have died, with a fourth of those blood clots. So it was amazing that she was still alive. And then we were able to, lyse them, free them up, and then I actually called in an interventionalist, a radiology, to come in and pull clot out. Because on a CT scan, you only see where blood flow stops, right? But you have no idea how long or how big that clot is. You just know that it's occluding on a CT scan. And he came in and did his thing, and he said he was pulling out like 20 centimeters of clot in all of these arteries, like just clot everywhere. And he couldn't believe that she was still alive. So she went to the ICU. She was there for a while, and she got out. And she came back to the ER to try to find me, and one of the nurses that had taken care of her and, thank us and whatnot. And she came back like 3 or 4 times, and one of the nurses finally was like, he's actually in the ICU over a Sacred Heart. He was in an avalanche, blah, blah, blah. And eventually I, got out, and I needed hand therapy to try to keep all of my joints, loose. In the hopes that eventually I would get, function back. And when I went to the occupational therapist to get all that stretching and stuff done, she was working. She's a technician for the occupational therapist, just like an assistant, which was kind of crazy that we saw each other. And she was like, I was trying to find you. And so long story short, she's watching our kids. So she's just trying to get into occupational therapy school. So she's working in the office, and she's not in school right now. And she's young and certainly can use the money, and so it worked out. So that was a nice.
So I'm confused. Is this to convince her to go off birth control and have her own kids, or to convince her to stay on and not have kids? Or?
So she was. I don't want to get into her personal life, but she wasn't on birth control to prevent birth. She was on birth control to control menstruation issues. And so it was like, well, we can try this. So she tried that, but as you know, birth control can increase your risk for developing clots, and for her, it obviously did. But so she was on blood thinners for months, and she got repeat echocardiograms, because sometimes when you have clot that bad, it can cause permanent damage to the heart, because the heart's pumping against all of that resistance coming back. So she can have right heart strain, significant right heart disease. She can have valvular problems, all sorts of stuff. But with all the repeat echoes, she's got nothing. She's completely healed with no lasting effects after she almost died. So pretty cool. All right. Back to what I know you guys have just been waiting for and love, the conduction system. You guys, hopefully some of this is a review. You guys understand that the whole conduction system and the automaticity and where it starts. SA node is first. Then it sends a signal to the AV node. When the SA node fires, there's a little bit of a pause, and then when the atrium contracts, you get the P wave, right? So when we're talking about a sinus mechanism, sinus rhythm means that there is a normal symmetric P wave with a normal interval before every QRS, right? That's sinus. And that's basically a kind of a shortened way of saying that we have a normal signal coming from the sinoatrial node. Things that can mess it up, medications, diseases that will cause the heart rate to increase, slow down, the contraction of the atrium to change. There are different things that can change that mechanism. Sinus rhythm. So sinus rhythm is that normal heart rhythm, reflects normal electrical activity. So the SA node fires first and faster. It's the primary pacemaker. So this is heart rates by age. You guys know that heart rates are certainly faster in infants, and they slow as we age. And for people that are in really good shape, you can have a heart rate that's even lower than 60, and they're normally physiologically bradycardic. So how do you recognize a sinus rhythm? So sinus rhythm, you look at your rate first. Quick and dirty way to do the rate. What's the rate of this rhythm strip? I know it's 60 to 100, but more specifically, what do you think the rate is?
75.
150, 100.
75.
Yeah, it's just under 75. You're thinking, around probably 70 to 75. So you pick an R wave that's already on a solid box, right? And it's really easy to go from there. 300, 150, 100, 75. Good. So you're looking at the PP interval and the RR interval and making sure that they're regular. And you can kind of take a glance at it, and you can tell without studying too specifically if that's all together, right? Now, if they're tachycardic and you really kind of don't know, you can always take another piece of paper, lay it across here, put a mark here, put a mark here on your piece of paper that you laid across the EKG, and then take that piece of paper and transpose it on the other ones and see if they're equal, right? You can do that with the P waves as well. All right, so P waves normally for sinus rhythm, they're upright in lead 2, and it precedes each QRS complex. The P waves all look the same. PR intervals look the same. PR interval is between 0.12 and 0.2. And then after you go through the P wave, you look at the QRS, and from the beginning of that Q, or I should just say the beginning of the QRS complex, does this rhythm strip have a Q wave? It might have it does have a little bit of negative deflection there that you can see in some of them, right? That one doesn't look like it has much of a negative deflection. That one is the one that looks like it probably has a negative deflection, and so on and so forth. But regardless, the QRS doesn't have to start with an absolute Q wave. But you're measuring from the beginning of the QRS complex to the J point, right? On how wide that QRS complex is. And this one is about right on the money, right? About 2.5 boxes. All right, so sinus rhythm. Rate between 60 and 100. You've got regular intervals. You have a positive upright P wave in lead 2. P waves look alike. They precede every QRS complex. Your PR interval looks normal between 0.12 and 0.2. So that's what boxes? Between 3 to 4 boxes, about, right? Or is it even more? 3 to 5 boxes for that PR interval. And then your QRS duration is normal. And that's a normal sinus rhythm. So sinus bradycardia is basically all of that except for slow, right? So the SA node is just firing at a rate slower than normal for the patient's age. In adults and adolescents, the sinus bradycardia has a heart rate less than 60, of course. P wave still looks good. Your intervals still look good. Your rate is slow. PR interval is still good. QRS duration is still good. So this sinus bradycardia at 46 beats per minute. Probably should have asked you up here, what do you think the rate is? Now I gave it away. Let's see if this is even right. Let's see, 300, 150, 175, 60, 43. It looks slower than 46 to me. What do you guys think?
40, just right around 48.
300, 150, 100, 75, 60, 43. So I would say it's slower than what they're saying, 46 beats per minute. But if you want to be completely accurate,
Count the tiny box.
count the tiny boxes.
That's what
Divide into 1,500. But also, there's some ST segment depression, correct? All right. So we went through all of that. So what causes bradycardia? So sometimes we can become bradycardic in our sleep. Everything slows down when we're asleep, right? Parasympathetic kind of takes over when you're sleeping.
Sorry to interrupt. Basic question again here. Can we go over just calculating the rate again real quick on that last slide, and then take a walk through it?
So what's the quick and dirty way?
60 and 50.
So what's Okay, so that's the middle. I guess that's the most I think effective, meaning that it's fast and almost accurate. But what's even faster than that, but less accurate?
6 second rule.
The 6 second rule. Okay, see these hash marks?
Oh,
How many big boxes are in between the hash marks? 5. How many seconds is each hash mark? 0.2. So how many seconds? So this is 0.2. So how many seconds in between the hash marks? 1 second. So 2 seconds. So usually in a full strip or on an EKG, you have these big hash marks, right? And you can count the number of R intervals within the big hash marks that will be either 3 seconds or 6 seconds. So you can quickly, if it's 6 seconds, then you can just count how many R intervals are within that hash mark and then times by 10, right? It's a quick and dirty way to find the rate on a strip. Or you can just count 6 of these things for 6 seconds and then count the intervals between whatever hash marks you devised. But that's a quick way. Usually all your EKGs and all your strips will have those hash marks that will tell you seconds, right? And then you can calculate that. If you want to do it by the 300 rule, right? Instead of the dividing into 300, the best way is just to memorize that you pick an R interval that's already on a bolded box, right? So that's pretty much right on that line. And then you go over from there. So this would be 300 beats per minute. This would be 150 beats per minute. This would be 100 beats per minute. This would be 75 beats per minute. This is 60 beats per minute. So if you had R intervals at any of those spots, you can tell real quick how fast it's going. And then 43, and that's why I say this is less than the 46 beats per minute. I don't know exactly how they calculated that, but it seems less.
I'm pretty sure that one is actually 50, not 43. It's the next one.
It was
60, 50, 43. Okay, okay. All right, so there you go. Does that make sense?
Good job, Greg.
So you're memorizing
Thank you. I require your application.
the solid boxes.
thank you.
Any other questions on that?
Why wouldn't we just look at the monitor
Because we're paramedics.
No, but I mean, realistically, what is this? We're never really gonna use this, right?
Good question.
Put it on the test.
Well, no, I just don't see the practicality of.
Well, if you're gonna judge, if it's irregular, you need to know the range.
So if it's irregular, and this sometimes is a pet peeve of mine for nursing staff in the emergency department, if you have an irregular rhythm and they're on the monitor and their rate's jumping around, and I will get somebody that would come and tell me in a patient that's AFib, like every 10 seconds, hey, their heart rate is 30. Or, hey, their heart rate, and be like, well, how long was the heart rate 30? Oh, for like 2 seconds. Well, that is just because the monitor is always calculating the average of what it shows on their little strip, right? Their strip shows how many heartbeats in like 3 seconds or something. Then it does a calculation, the average, and says what that would be in a minute. So if you have in that irregular rate a widened or a couple of wide beats, it'll say that the heart rate's super low. If you have a couple of really narrow beats, it'll say the heart rate's super fast. What is the most accurate way to get a heart rate on an irregular patient? Feel their pulse and count it out, right? Really over a minute. You could do it over 30 seconds. That's going to give you a pretty accurate. If you do it over, shorter than that, like the 15 seconds, which most of us probably do, in an irregular heartbeat, that might be off on like their overall average, So what the monitor says is within like a 3-second interval, and you want an overall average. So you want to watch that monitor for a good 30 seconds before, at least in an irregular heart rate, before you can decide what their kind of baseline average heart rate is. Does that make sense? So that would be the only time where you really don't need to trust the monitor. But so finding the rate on an EKG or on a rhythm strip, I don't know. I think back in the day, maybe all of those calculations and stuff weren't there, and so this is more important. But for you guys, just know how to do it. Whether or not you're going to use it a whole lot, I don't use organic chemistry anymore. But for some reason, I had to memorize every aspect of that bloody subject. All right, so sinus bradycardia. This is basically, again, it's all the same thing as sinus. It's just slower, right? What causes it? Sleep, well-conditioned athletes, and then just younger people. A good percentage of just younger people will have slower heart rates at rest. You know what? I picked that picture. I picked that picture for you, Craig. And ironically, you were the one who mentioned it. They were red too. 'Tis the season. So bradycardia is a common dysrhythmia with MI, for inferior and posterior MI, right? Because that's when it's going to affect the rate. If you have decreased blood flow to those parts of the heart where the conduction system is, oftentimes you're going to become bradycardic. So if you give somebody who's bradycardic with a heart attack, has bad right-sided heart, and you give nitro to vasodilate, and further decrease their blood pressure, and then they're really in trouble. They got no blood flow to those coronary arteries. All right. Also causing bradycardia, we know this, that vagal stimulation, right? Your acetylcholine released into those synapses. So vasovagal things that you can do to decrease your heart rate. And you guys have done this with people that have SVT, right? You want to decrease their heart rate, so you have them do these things that'll stimulate their vasovagal response. You don't try to make somebody vomit, of course, but vomiting can do it. Any kind of straining, increasing that intrathoracic pressure. People are sitting down pooping and they faint. They vasovagal themselves. Some people are super sensitive to just showering. And if they get that shower that hits their neck a certain way and stimulates their carotid artery, they pass out in the shower.
Does that have to be cold water, or is it just-
No, it's the physical stimulation of the shower hitting the neck. That's why in SVT, sometimes we'll just go up to them and massage their carotid artery to try to stimulate and make them bradycardic. I'm going to make myself lightheaded. So other causes, MI, disease of the SA node, vagal stimulation, hypoxia, hypothermia. You guys know Cushing's reflex with increased ICP. Heart transplant. So transplant patients, why is that tough?
Because they don't have the synthetic.
Yeah, so they don't have the sympathetic or really parasympathetic. So they're really just going off of the automaticity and whatever medications they're on, right? So they sometimes they have, it's difficult. They don't respond or have those reflexes
So
that
do
the
they
normal
spend the
person
rest of
does.
their life with just a flat heart rate?
It depends, but
If they get scared, it doesn't go.
yeah. They're super calm, man.
Yeah, that's right.
All right. Then, of course, your medications, calcium channel blockers, DIG, we talked about, beta blockers, amiodarone, sotalol, all those things will cause bradycardia. What do you give for calcium channel blocker or beta blocker overdose?
Or not good. So what do you give for diabetics? Glucagon. Thank you.
Glucagon. All right, yes, you give glucagon for these patients. You can try atropine, and it might help a little bit. You guys don't have atropine?
No, we do.
You guys have glucagon, though.
Yeah,
Right?
we do.
Yeah.
I don't think enough to reverse calcium channel blocker, beta blocker.
How much glucagon do you guys have?
Just one needle. I don't know.
One might do it, depending on the overdose, but one can certainly help. All right. So, bradycardia. If somebody's bradycardic, do you care? You care when? All right, if they're symptomatic. And symptoms, of course, all the symptoms that go along with not enough blood flow to vital organs, right? So mental status is a big one. You guys will know beforehand with the low blood pressure, if they have cardiac disease. Sometimes if they don't have cardiac disease, they're just not getting enough blood flow to their heart. They can have chest pain, shortness of breath, of course, cardiogenic shock you can have signs of, so on and so forth. Cold, clammy skin is a big one that'll be noticeable. No treatment if they don't have symptoms, right? Things that you can do in pre-hospital: oxygen, fluids if they need volume, atropine, transcutaneous pacing if needed. So atropine is a vagolytic, right? So it inhibits what? Right? So what does it specifically inhibit? What does it bind to? Acetylcholine receptors, so that acetylcholine can't do its job, right? So inhibits acetylcholine. All right. And basically it just stops the parasympathetic innervation so that the sympathetic can then be more active. But it doesn't stimulate the sympathetic. All right, sinus tach. This is when the SA node fires faster than what they should be, right? It's sinus rhythm. Everything else is normal. You're looking at the P wave, the QRS, the PR interval. Everything else is normal. It's just too fast. The QT interval shortens as the heart rate increases by the numbers. But if you look at what was the fast and dirty way of looking at a QT interval, less than half of the R&R, right? In tachycardic patients, it'll be more than half of the R&R, but the actual length of the QT will actually get shorter as the heart rate goes up. So tachycardia in adults is above 100, in infants, usually more than 180. Here it's 200. Younger kids, more than 160. Usually you can tell if their heart rate is tachycardic for that patient. They'll have some kind of symptoms of that tachycardia. So of course, recognizing it, you're counting them out. How fast is this one?
Very good.
Yeah, probably around. Yeah, probably around 135-ish. Yeah, right? Less than 150, greater than 100. Probably more than 125. All right. P wave. I mean, sometimes you'll have outliers, but generally, as you're looking at all the P waves, they all look about the same, right? All those PR intervals look about the same.
So where's the baseline or the isotonic line in that one?
So this one's a little bit tough to see or to find. Where is it? Because your P wave is so close to your T wave, you don't have a TP segment, right? Because it's too fast. So where is your?
Is it that little dip right after that T wave?
Your PR segment, right?
So do we not have a Q?
Does not look like you have a Q. I mean, maybe in a couple of them you might see a little bit of a Q, but for the most part, no, I don't see a Q. And this one could be argued, I mean, very minimal ST segment depression, depending on how you argue where the isoelectric baseline is, right? But I would say minimal ST segment depression.
So what's to stop you from saying that there's a very pronounced Q and that you have ST depression if you raise that ISO bar to?
What do you mean? So if you
Let's say,
were
yeah,
like,
let's say
I
that-
want the isoelectric base to be right there.
Yeah.
Is it not?
So what's your question?
Well, so because you were saying there wasn't a Q wave in this, is that correct?
Right.
So that was where you were just pointing. Once you have the Q wave there.
Well, I guess it depends. If the isoelectric line was up here and you had a deflection right after the PR segment, then that would be a Q wave. But right here, the isoelectric line goes and you have no negative deflection, right? It goes straight up. And it goes down into the S. And then your J point, probably about right there, might be a little bit below the isoelectric line. So that's why it's arguable on whether or not that's true ST depression. Might be very minimal. If anything, less than a box, less than a millimeter. But yeah, so it's important to be able to identify the isoelectric line, right? Because everything comes up or goes off of that.
Okay.
So what?
I guess my question was, who sets where that ISO wave is? Because if it was originally that higher line, then yeah, you would say, okay, you definitely have ST depression. You have a pronounced.
But why would it be that higher line?
Because I'm new.
I think what he's saying is because he's saying what's to say that the first drop after the P wave isn't the Q wave, and we don't have a PR interval. I think what it is.
Oh, so you're saying that?
Yeah.
How do you know that this isn't where the P wave or the segment ends, and that's a negative deflection?
Right.
Well, because you've got a straight line here, and a Q wave is never going to have an iso, or it's never going to be kind of a neutral.
Okay.
It's going to have a sharp deflection down and up. Does that make sense?
Mm-hmm.
And you're trying to identify, so even if the patient is tachycardic, that PR interval should remain the same, right? It should be 0.12 to 0.2 long, right? It might shorten up a little bit when the patient gets really tachycardic, but as a general rule, the PR segment is not going to change. So you can in a tachycardic patient, you can generally count on the PR segment to identify where your isoelectric line is. Now, if a patient has a tachycardic with AFib, RVR, and has a WPW, so that a delta wave comes down here, and you don't have any straight line, and you're like, well, is that my PR segment is just super small, or is that the Q wave? In that instance, where you don't have a good straight line there, then yeah, it's going to be difficult to say where my isoelectric line is.
Is the J point helpful at all in finding the isoelectric line?
No, because the J point
Can change.
can be above it, can be below it, and the J point's not always at that line.
But with a normal sinus tack, you can kind of see the J point is adjacent.
Right,
Line.
right.
But it just happens to be in this case.
Yeah, this is just a little, I think this one probably shows your best J point. You see how that J point is just maybe a box under the isoelectric?
Yeah, sure.
So in a normal patient, or at least in sinus rhythm, your best, I guess, your best strategy of finding the isoelectric, because sometimes you get an EKG, you get a 3 lead, and like you'll have a general kind of increase in all of the waves, right? And you're like, well, where's my baseline? Then I'll like jump down. In a normal heart rate, the TP segment is going to be, when everything's at rest, nothing's happening. That should be your kind of isoelectric. You just don't have that in a tachycardic patient, and you have to go to the PR segment.
So the depression, all that's telling us is that the T wave is starting to vary, or is coming right off of the S wave. Or what do we?
The T wave? No, so this is a T wave. The T wave and the P wave are getting
Mixed together, yeah.
Yeah, so the hearts, they're so tachycardic that it's firing before it's fully repolarized.
So
Sometimes you never even see the P wave. Sometimes the P wave gets buried in the T wave when they get really fast.
why does the QT interval speed up with that electrical signal? I mean, how's it traveling any faster? It's got to go through all the same cells and everything.
Right. That's a good question. The QT does shorten when you get really tachycardic. From a physics standpoint, why that conduction is any faster? Repolarization. Well, I think the repolarization is where it's probably faster, and it might be that it just doesn't fully repolarize before you get the next contraction. But as soon as you get the next one, that's the end, right? That's the end of the T wave. Even if here the T wave, you don't even see a definite end, right? If this was a slower, the end of your T wave would be probably like down here, right? But here, the end of your T wave is here, where the P wave starts. So that's a shortened QT. So it's just that it's not fully repolarized.
It makes sense that the TP segment is short because it's repolarized when it's ready to go back to work.
Mm-hmm.
But the QT, that's all.
Well, it's just because your T wave is shortened, so that shortens your whole QT. Because the QT is from the Q to the end of the T wave.
Uh-huh.
Well, in a normal circumstance where this patient was at a normal rate, that T wave would come all the way down here, and the end of the T wave would be like right here.
Okay.
Does that make sense?
So it is that.
And because it doesn't fully repolarize, that T wave starts before the ventricle has finished resting, it shortens that QT
Okay. Okay.
mathematically.
Although it's shorter, the primary short.
I don't think it speeds up the conduction at all.
Okay.
It just shortens the
Q, essentially
process.
The TP section is really short.
Yeah. Yeah, TP section's gone. So everything else basically stays the same. PR interval is still like I said, it may shorten a little bit with faster rates, but for the most part, that PR interval stays. All right, so what causes sinus tach? You guys know. Anything that would cause a increased demand is going to cause the heart rate to go up. Also, medications, caffeine-containing beverages. What do you think the half-life of caffeine is?
6 hours. 8 hours.
Yeah, you guys are pretty good. 6 to 12. So yeah, you can drink coffee in the morning and still might not be able to get to sleep at night. And you know what? I just barely found. You know those? What are they called? Like sparkling ice or something? It's like flavored carbonated water. I don't know. Sparkling ice. I've been drinking those a little bit, and I drank one the other night, and I could not get to sleep. I was like, what the heck is in this stuff? And there's like a whole bunch of green tea extract in those things, so it's been keeping me up. Those bastards. All right. So what do you do with sinus tach? I mean, the reflex response is given fluids, right? Which is correct almost always. Of course, they could be tachycardic because they're in pain, and that's a sympathetic response to the pain. Could be a medication or a drug. Fever is going to cause the tachycardia. Anxiety will cause it. And then, of course, any kind of increased demand on the heart.
So that's it, reducing fever and anxiety?
Yeah, so this is directed at correcting the underlying
Oh,
cause.
gotcha.
So correcting the tachycardia, you want to reduce the fever and anxiety. All right, so an arrhythmia. So this is when the SA node fires irregularly. That's a sinus arrhythmia. So it's sinus because you're still getting a full normal complex coming from the SA node, but it's irregular in its timing. So respiratory sinus arrhythmia is the most common example of that, where it changes with breathing. And apparently our childlike friends, colleagues also have that. Then you've got the non-respiratory related ones. Arrhythmias still are usually within the normal rate, at least with the overall rate. And then, of course, if you got it slower, it's a sinus bradyarrhythmia. If it's faster, a sinus tachyarrhythmia. How do you recognize it? Usually, you get the intervals of the shortest RR interval and the longest RR interval, and that'll kind of give you a range. You can get an average from that. But the rhythm is irregular and can be phasic with respirations. The heart rate increases with inspiration, decreases with expiration. Everything else remains the same. Oh, I should have had you guys do it. Oh, shoot. Oh, that one seems a little bit longer than that, huh? 15. All right. So we got that. We talked about respiratory children and adults less than 30 years of age. So yeah, I guess you guys are young. You can still have those respiratory sinus arrhythmias. Your hearts haven't gotten old and crappy yet, like mine. Yeah.
It's all the sparkling ice beverages.
I know. It's that green tea. Apparently the green tea extract is supposed to be good. I don't know.
It's called.
The what? I think it's all marketing.
Eastern medicine.
It's all just marketing and trying to get people to buy into something. All right, non-respiratory. This is in your older people. This is with MIs, increased intracranial pressure, yada yada yada. What do you do about it? Nothing. If they don't have any symptoms, if they're hemodynamically compromised, then you can certainly give atropine. You can also give fluids. Sometimes it's a metabolic abnormality, and fluids can help buffer that ion change. But so an SA block. We'll talk about this a little bit more, but it's sometimes called a sinus exit block, but not really. So the SA node generates the impulse, and it's blocked as it exits the SA node, which results in sometimes a skipped, or I should say an absent complex. See how all the other RR intervals, and then there's just a skipped one where you think that there should be a complex sitting right there. An SA block is different than a AV block in that an SA block still has a normal PR interval, right? A first degree AV block has a widened PR interval, right? So that's how you can kind of differentiate the two. Also, a first degree usually doesn't have a skip beat. All right, everything else is the same. An acute MI can cause it from where? Which side?
Right side.
Right side. So an RCA, which would typically give you an inferior or posterior MI. DIG can cause a SA block, and then you've got the other ones that affect the conduction system. TCAs can do it. And of course, your congestive heart failure, anything wrong with the heart, myocarditis, pericarditis can do it. Increased vagal tone.
So why is it just periodically you get no complex? If it was a block, wouldn't you?
Right. Because nerves aren't always all or none, right? You can have just enough blood supply to have a connection, and sometimes that impulse goes through, or at least most of the time that impulse goes through, and then every now and then it might not because that nerve is just not optimized, right? So if they're hemodynamically compromised, meaning you're getting a more frequent block and you're skipping a lot of beats, and so that they're significantly bradycardic, you can give atropine. You can also do transcutaneous pacing, and that patient, if it's a continuous problem, will need a permanent pacemaker. Sinus arrest. No impulse is generated. So the SA node fails to generate an impulse. If the SA node fails to generate an impulse, what takes over? The AV node. So you get AV junction, possibly the ventricles if the problem is affecting the AV junction as well. You can, even normal people can have, periodic sinus arrest. But it's short-lived. How long is that arrest?
2 seconds.
Yeah, about 2 seconds. 2 seconds, is that something to get super worried about?
Would a person feel that? Would it be like
They might feel a flutter, and then they go into the doc and they say, "Oh, I'm feeling a flutter in my chest every now and then." But the doc never sees it, so the doc can never say what it actually was. You can put patients on a Holter monitor where they are having a strip or being recorded over like 48 hours. But sometimes we just never see it, and we never figure out what it is. But it could be a sinus arrest, could be, most of the time it's a PVC, preventricular contraction, where the ventricle fires without the P wave, and you get a beat right after another beat. And so the normal person, most of us have them, I should say all of us have them periodically, but we don't feel them. Some people feel them. Some people feel normal ones. Most of the time, if you're feeling them, then it's either happening too often because of an electrolyte abnormality or some other kind of injury to the heart. But we do have, you can have normal arrest, normal PVCs. It's a problem if you're symptomatic, right? If it's happening often enough and they're symptomatic, they're feeling them, they're like, man, it's happening. I feel them like a couple times a minute, then that's an issue. And they probably are going to need a pacemaker. All right. How do we recognize it? We know how to recognize it. What causes it? Hypoxia, MI, hyperkalemia, DIG. Certain medications can cause it. Most beta blockers, calcium channel blockers. Name some calcium channel blockers. Diltiazem. You guys know any more? Verapamil. You guys seen patients on verapamil? It's still used. It's less common because I think diltiazem is kind of taken over for the most part. There's other medications that have properties that do both. So you guys, those are the ones you have to memorize this week? Well, those ones are easy, right? Well, those are ones that you guys use or are common or see commonly, right?
Well, never seen norepinephrine.
No, you guys. I guess you guys don't use it either, but yeah, norepinephrine is levofled. You guys probably know the trade names more than some of the generic names, but. All right. Pregnant women will use promethazine and prochlorperazine. All right. Yeah, compazine and phenergan. That's it. I mean, it's kind of a intro to EKGs, understanding the waves, segments, the time, or I guess the time intervals, what's normal, what's abnormal, and helping you start to look at a complex and be able to kind of break it down. And then tomorrow, we're going to learn about all the problems.
So looking at the sinus arrest and sinus block, they look like they're pretty similar to each other in what they show, aside from the heart rate. A little bit different.
Sinus arrest and sinus block.
That we just talked about.
The blocks still have a P wave. The sinus node is still firing.
Right.
Arrest, there's no P wave.
Arrest, there's no PQRS complex. There's just nothing. And a block will still show. So you're talking about a third degree block, which is like a sinus block?
No, obviously what we just talked about.
I don't think we had. Did we have a sinus block on here? Okay, SA block. Yeah, SA block is an exit block.
Okay,
and you still have a P wave.
you still have it. Gotcha. All right.
Do we have quarter after?
What's that?
We have quarter after, right?
Yeah.
Can we go through some of the, I don't know if you have it on there, but like we have chapter 3 and chapter 2 practice release scripts in the PowerPoint.
Really? Well, we can go over some of it. We have lecture time where we're going to specifically go over all of that stuff. But we can do as much as you like.